Dr. Timothy Lavinka. He's a board-certified urologist from the USA, the Urology San Antonio group. He'll be speaking today on sexuality and aging. So please welcome Dr. Lavinka.
I'd say hold your applause till you see if this is good or not. How about that? So I can speak in the mic. I don't have to turn it on, right?
Yes.
I'm kind of a wanderer. And I took my jacket off. It's kind of warm in here. I hope you guys don't mind. I got into sexuality in about 1999. I've been in practice almost 10 years, out of my residency about the same amount of time. And can you hear me? And there was a common visit in my office from, at that time, what I thought was an older lady, as I'm getting closer to her age. She was about 72, and she came in to talk about bladder infections. And at the end of the visit, she did the, hey doc, wait, when you're way behind and trying to get your foot out the door, and you already got your foot hooked behind the door. And hey doc, wait hit me right between the eyes. And she says, you know doc, I only get these infections when I have sex. And I said, okay, well that's common. A lot of ladies, as you get older, we can fix that. She says, no, you don't understand. She said, I'm single, and unless I do it in a certain position, I get infections. In the other positions, I'm okay. And I go, okay, well maybe we can work around that. She goes, well, it's not the position that you would find somebody on a first date and have sex and say that's the only way you can have sex. And I said, okay. So I was about 8 shades of red by then. And you're my mom's age. You shouldn't be having sex in the first place, much less talking to me about what positions you're doing. So I vowed from that moment on to learn more, and I still turn red. But as those 72-year-olds get closer to my age, I find it harder to talk about the 20-something, to this 20-something about that. But I understood at that time that becoming comfortable with talking about sexuality is anybody's responsibility who deals with a wide variety of patients and their sexuality, be it a primary care, nurse, mid-level, or physician. And certainly somebody that is dealing with these issues all the time needs to become well-versed in it. And if you can't, or you're uncomfortable, at least find referral sources. I would say that's the take-home message. If you can't help somebody, find somebody who can. Because there are people out there, there are people like me out there who would gladly speak to people about sexuality. I make it a big part of my practice. I go to seminars, I participate in international organizations. It's something that I truly love to do. I love to talk about sex, and there's my topic right there. So let's talk about sexuality and aging. First, we don't automatically have a decrease in desire. And I see this in my patients who come in later in life. Something happens, they've been together 40 years and desire had dwindled, and then the nest gets empty. Or there's a life change where someone had a major illness and makes it through the illness, and now they realize that life isn't certain and their desire for each other deepens. It changes. It changes. It's not the same as when we're younger, when desire is almost an autopilot, but it's something that we can learn to tap into. And if we learn to find what is in our partners that is desire, and to not turn it off, as we sometimes tend to do as we get older and farther along in a relationship, then I think we can find out that desire is something that's there all the time. Learn how to tap into it. That's the most important thing. And recognize that, desire, when you know the other partner and you know what the response is going to be, sometimes that can actually be better. And there's not all the problems with a new relationship and trying to feel each other out. So recognize that this change is both psychological, it's due to a change in our relationship status, length, our own personal health, but fundamentally it is also associated with physical and brain changes, because you can look at functional MRIs of patients of people in their 20s when they're sexually stimulated and look at the same areas of the brain and somebody who says 40 years later that they're just as stimulated, and the neurons just don't light up as much. The fireworks just don't go off. And that is independent of length of relationship. So something happens as we age. Our response to sexuality declines. Now one might say that that's an evolutionary thing, which since we shouldn't be making babies at that time, well, desire should go down. But the brain is capable of responding, and many times when we find a new relationship, for instance, or if someone has been off treatment for a while and gets on treatment, one of the things we found with Viagra when the studies first came out was that when you restore the function and the desire comes back, then the brain starts to come around too. And men become much more like women in their desire as we get older. So our bodies don't react as easily also. You may have vaginal dryness. You may have certain positions that are uncomfortable. A man may have quite a bit of difficulty getting an erection. As one of my patients says with her about her husband, well, when he gets one, we're going to do it, no matter what or where or when, because we don't know when the next one's going to come. So maybe that's how you have to adapt. And of course, if there's little kids around the house, that could be a real problem. But they used to scoot their grandchildren out and make it happen. So I think what we do is we recognize that these are changes in our bodies that are going to happen. They're inevitable, and we need to adapt to them. So I should put the girls first, I know, but I guess men's came up on the slide and it was too late to change it. But I don't want to talk too much about testosterone, all the controversy that's out there right now. Believe me, it is a daily discussion that I have in my office. Probably a third of my patients are on hormone replacement therapy, both men and women. And we have very long discussions about these issues right now. I don't want to get into that controversy. I will tell you that this controversy is overblown, that these last two studies that have come out have been the only studies in the last 15 years that have not shown benefit, and very strong, good type of data that show benefit to testosterone replacement therapy in men. So I think we need more time and to kind of stop this rapid pendulum swinging that happens in medicine. When one study comes out, everybody runs over here and jumps in this camp, and another study comes out, everybody runs over here and jumps in another camp. What we need to do is think, and it's very important to somebody like me who's been doing hormone replacement therapy for 25 years, and I've seen these pendulums swing back and forth a few times, to hold steady and counsel your patients. And that's the most important thing. Testosterone is still very important. It's not all or none. There are some men who have low testosterone, and I treat them, and when they stop it, sex goes away, both desire and erectile function. You put them back on testosterone, and it comes right back. And there are some men who, it depends on their level. If I replace them just this much, they don't get the response. If I give them just a little more, they do get the response. So for a group of men, testosterone is critical, and it is everything, desire and sexual function. For other men, testosterone is more of an enabling hormone. It allows them to have desire so that they respond to it. It improves the health of the erectile bodies so that they may respond to a testosterone replacement, I should say to a medication like Viagra. So for them, testosterone is something that is kind of in the background. But we don't really know what happens to testosterone as we age. We don't routinely get testosterone when we're 20, when it's at its peak. So for some men, the testosterone may be very high, say in the several hundreds. And then when he gets down to 500, when he's 70 years old, that's not enough for him. Normal levels are between about 300 and 1,000, just for instance. So for another man, 300 may be just fine, or even 250 may be fine, but we don't know where they start. Now we do have things like the Massachusetts study of aging that did look at this, and they found that the rate of decline of testosterone was about 2 to 3% per year, starting about age 35, starting very early. And obviously for some men, it's faster. What we have recognized, and much as we see in Western civilizations where sperm counts are declining, testosterone is also declining. We don't have a male menopause. There's no such thing as menopause because we don't have menstrual periods. And there's not really an andropause because testosterone doesn't just stop like estrogen does after the last period. But we have a slow decline. And for some men, that can be absolutely indistinguishable from the effects of aging. For other men, is something that they really distinctly recognize as their male hormone and its desire and its function. So I think when you look at all the different things that could be from testosterone, many of them are things that we can associate with just fatigue. But the things like changes in body hair and characteristics, changes in sexual function, changes in desire, depression, many of these things, they're not just getting older. They can be low testosterone. And just another background to this testosterone controversy. We spent 15 years finding out how to do testosterone replacement therapy right. In 1995, there was a study that came out, and this is an independent study. It was not sponsored by any pharma company at all, that looked at only 5% of men who had bona fide low testosterone were being identified. So we were assaulted with our failure. You know, you guys need to look for this. You don't know what you're looking for. It's not just depression. Don't put them on an antidepressant. Check their testosterone. Okay, message received. So we did this. We looked for it. We found good products, gels and things, and shots like that to do hormone replacement therapy. And for 15 years, we've tried to identify patients more, given the testosterone more. And then now these studies come out. So that's that pendulum I'm talking about. So you can understand the background that I'm looking at. So there are options. Pills are not good because they affect the liver in men. But mainly there's gels and there are shots. And then there are longer term forms of testosterone, either implanted pellets that last 4 to 6 months, or a new shot that's actually out just this year in the United States called AVEED, A-V-E-E-D. I haven't added it to my slide. And that's a 10-week shot given intramuscularly in the buttock. And we're starting to use this in the office, and it's very well received because it keeps you from having to rub some gel on your shoulders every morning after a shower and to get a shot every 2 weeks. With every 2-week shot, you're too high for a few days, just right, too low. Too high, just right, too low. So the yo-yo effect bothers many men. So let's look at erectile function by itself. And obviously in the day of Viagra and all the ads on TV, it makes it seem as if all you do is pop your little blue pill and everything's fine. But recognize that erectile dysfunction many times for a man is the canary in the coal mine for other things that are happening. Cardiovascular disease, depression, thyroid, all these things can be in there. Even stress. When we're younger, we can have sex in a hurricane. I will say I did. I was in Galveston during Hurricane Frederick, and yes, we did. We had sex during hurricane. But as you get older, you need a little bit more stimulation. We guys become more like the women. So what are the signs and symptoms of erectile dysfunction? Well, I don't need to tell you that. We kind of know. But the bottom line is, for many men, they don't recognize their dysfunction. And it is their partner who tells them, it's not as firm as it used to be, you're having more trouble, I'm not as satisfied. As a woman ages and needs more stimulation, sometimes the fault is in him. Yes, it is. So obviously we know all the options out there with what I call the big three, not the Spurs big three, Viagra, Levitra, and Cialis. We've added a new one now called Stendra, which is a faster onset, about 15 minutes to 30 minutes depending upon when you take it. It seems to be very effective. Then there are other things besides the pills. There are things called the VED, a vacuum device, sort of a glorified bicycle pump that creates a vacuum, and then you may or may not have to slip this little O-ring at the base of the penis to maintain the erection. We use that a lot. There are injections. Over 1 million men in the United States were getting injections. Yes, directly in the heart of the matter, absolutely. I know it sounds owie, but the owie is usually very, very much worth it because it gives you an erection that an 18-year-old would be proud of for about an hour and a half. So one day I remember using these. Well, when Viagra came out, you know, let's take a pill instead. So then there's something called MUSE, which stands for Medicated Urethral Suppository for Erections. It doesn't mean like the pretty hot girl that's going to get me all excited. But the name was clever anyway. MUSE is an intraurethral pellet. That's another owie, where you actually put this little suppository in the urethra. And it works also. It's a little painful, as you might imagine, but it works. And then there's, of course, the penile implant. If you look at satisfaction, the actual lowest satisfaction starts with the pills, and the best satisfaction is with the implant. Obviously, the risk is the highest with the implant, but as you go up in terms of risk, the shots and the injections have the highest satisfaction rate for both men and their partners, and the lowest is the pills. We are working at better pills. I think Stendra, that just came out, as I mentioned to you, is an improvement in the ones that currently exist. However, stem cell, all these things are on the board now for research for erectile function. So you want to know what's in it for the ladies, right? So the women's sexual response. You see the man there. I'm sure you've seen this on the internet. One on and off. That's how we are. I've seen this where it's a 747 console. you name it, all sorts of things like that with a female sexual response. Yes, indeed, more complex, and such thus makes it more difficult to find the pink Viagra as we might look for. But let's look at it, since this is about aging, pardon me. Since this is about aging, we need to talk about menopause and menopause's effects on sexuality. Mainly, menopause affects vaginal tissues, but it also affects everything else. It affects the brain, it affects the body's response, it even affects nerve sensation. And that's why estrogen is so important. Again, this is too short a time frame to talk about hormone replacement therapy and that controversy. What is it about hormones that are so controversial? We're born with them, we have them all our lives. I don't know why it's so controversial. But decreased desire is the most common complaint of women after menopause. Vaginal dryness or pain on intercourse or sexual function, decreased arousal, and then changes in orgasm. Maybe a woman can't get orgasm where she could before. Maybe she used to be multiply orgasmic and now she can only get one. Maybe she has to have an absolute specific sexual activity for a certain period of time to get to orgasm. So these are the kinds of things that can happen to women after menopause. So a little difference between men and women in desire and arousal. For men, desire and arousal are pretty obvious, right? And they are closely linked one to the other. A woman can actually have genital arousal. A woman can lubricate, have labial and clitoral engorgement, and not be psychologically into it. So many times when you start fooling around, you may feel yourself get the genital response, and hubby wants to go for it, and then all of a sudden, well, I'm not really there. And it took me a long time as a man and studying lots of sexuality to realize, well, that's pretty normal. And for a guy to think, well, you're aroused down there, why aren't you aroused up here? Well, there's a disjoint, particularly after menopause, between psychological and genital arousal, and they don't have to happen together. Now, what we have found in a lot of women is that the genital arousal leads to the psychological arousal after a time frame of stimulation. So it's a very normal part of the female sexual response to not respond at first. And when you get into it for a while, then you go, hey, this isn't so bad after all. Now I remember what we were heading for. And then give it time, and then desire comes along. So for a lot of women, that is the response. In fact, you may talk to women who never have spontaneous desire. Bothers them a lot, but they never have that desire for their partner. But once the process gets started, and when they get into it, and then the genitals get warmed up, so to speak, well, then the brain starts to come along. So that's the typical process of desire and arousal in women. So let's look at vaginal atrophy. My partner, Peggy Francis, Dr. Peggy Francis, and she can get away with this a little bit better because she's a woman. She always says that if she is marooned on a deserted island with 500 menopausal women and she only had one thing in her little black bag, it would be vaginal estrogens. And I think that that's very important too, because so many things that happen with sexuality happen because of vaginal dryness. And if you look at the number of estrogen receptors per gram of tissue, in other words, the need or the hunger of a tissue for estrogen, every woman knows the vagina and vulva are the most needy, so to speak. But next most needy is the bladder and the urethral control muscle. And then I always tell women, gotta put this down for a little visual here. I always tell women, between your hips, that's what you need. Do I even need that? Can you hear me? Between your hips, everything, the highest vaginal receptors, your hips, your pelvic floor, your genital organs, your vulva, and your vagina. Those are the most important things for you. Or do you need me to do that for
You do, so that people can hear
I'm sorry,
from
I forgot
afar.
that you guys have a satellite. Forgive me, I will use the mic. So those are the most important things for estrogen. Higher than the uterus, the breast, the brain, the skin, all of those things. So I think that's why women realize that the dryness leads to lack of desire, and that can lead to lack of function. So we're very aggressive about treating vaginal atrophy. Lubricants only treat the dryness. They don't reverse the problem. And lubricants that are associated with glycerin, if you look on that, or glycerol, well, studies show that they turn into something resembling glue in about 2 minutes of intercourse. So we're not a fan of silicone lubricants, which are just like your basic KY, all the things that you buy in bulk in the store, what we use in the medical field for lubrication. So we strongly believe in silicone-based lubricants. Now, they're a little slippery, and they can mess up your bed, so put a towel down, and no sex in the shower with silicone lubricants. We don't want to be responsible for any hip fractures here. Right? They are very slippery, all right? So I told you, no sex in the shower. You heard it here. So how do you do estrogen replacement in the vagina? Well, there's several different ways now. There's a new pill, again, called Osphena. A little controversy about Osphena. It's the first pill for vaginal vulvar atrophy, only indicated for dyspareunia, pain on intercourse. It's not really indicated for standard vaginal atrophy, so I really can't talk about it for that because that would be off-label use. So what we have right now is intravaginal creams, tablets, and an intravaginal ring. They all work about the same. Studies show that it takes about 3 months of aggressive vaginal therapy to get the vaginal estrogen levels back to where they need to be. If you take a group of doctors like me that do sexuality, and you show us a microanatomy slide of a woman fully menopausal, a vaginal biopsy, microanatomy, you give her 3 months of estrogen, and then you show another one, you get oohs and ahs from these. I know that's totally nerdy, but the bottom line is the tissues get very close to a younger woman's vaginal tissues, and estrogen is so critical. The tissues are so responsive, and it's not just the lining layer. It's not just the lubrication. It's the muscles. It's the nerves. It's the blood vessels. It's truly a proliferative hormone for the vaginal tissues. And studies have shown that by restoring vaginal health, you can actually restore sexual desire. Now, how does that work? Well, when it hurts, you turn off. So when it doesn't hurt, you turn on. And there was a study looking at a product in the vagina for helping vaginal atrophy that didn't involve estrogen to see if it was safe. And they found in their exit interview that these women didn't just have improvement in dryness, did not just have improvement in vaginal in comfort with intercourse, they had an improvement in desire. And some of them even had an improvement in orgasm. So when this gets better, when the vagina gets better, the brain comes along too. And I think that's the take-home message from that. So you can get Astroglide X. Well, the water-based are like Liquid Silk, Astroglide, KY, but they're not that great, as I said. Some of the better ones are the silicone-based, KY Intrigue, Astroglide X. There's a million of them. You can see them now. They're even at the HEB, CVS now. It used to be you had to go to the specialty shops and places you didn't want to park your car in front of, but now you can get them practically anywhere. You can also use olive oil, palm oil. These are very safe if you don't have an allergy to those things, and they're certainly natural. Now, there's things called Replens and Refresh. If you cannot get the vaginal health up, if a woman's still having discomfort despite vaginal therapy, I should say vaginal estrogen therapy, you can use vaginal moisturizers. I warn you not to do douching. Douching is not good. It destroys the normal vaginal environment, which is what we want to restore. And for so many women come in and they want to be clean down there, and we tell them what you need to do is stay away from that area. Get it back to normal with a natural product. And don't forget probiotics. Probiotics, I'm a big firm believer. Not just the, Jamie Lee Curtis looks great for 60. But the bottom line is that you have to eat like 16 jars of Activia every day to get enough probiotic. And even some of the expensive prescription probiotics that you can buy are not adequate. They're very good over the counter. You don't have to go to a Cost Plus Nutrition or a place like that. You can go to HEB. What you want is high colony counts, enteric coated so they don't get destroyed by stomach acid. You want multiple organisms, and you want them to be shelf stable so you can take them with you. And there's a lot of data about the improvement in our immune systems. I don't want to get into that here, but I can tell the difference in probiotic use, definitely in women who have recurrent infections. So sometimes none of this is working, and we cannot get the woman to comfortable intercourse. Then she needs to see a good, competent physical therapist to help relax, help open up. Sometimes doing massage exercises. Sometimes you even have to do vaginal dilation to get the woman capable of having comfortable intercourse. So what do we do when that's not working? Your hormones are good. You've had your vaginal treatments. Everything physically is good to go, and you're not there yet. But what do you do then? Well, then we have to work on that part of our sexuality that is the mind. The strongest by far sex organ in the body is our mind. So we educate. I had a woman come in the other day, And it was remarkable how little she knew about her own body. Now, there were cultural restrictions to this. People just didn't talk about their bodies in her culture. And so her husband had died, and she was now 68 and married somebody else, and they wanted to become sexual again. And she really knew very little about her anatomy. So just educating her about female anatomy and the sexual response was a huge part of that. So, as my other lady needed her position for comfort, that's pretty hard for her first time, but after that, find out what feels good. Find out what is your best response. Find out what doesn't hurt sometimes is the best way to do that as we get older. So this is a lot of tasteful erotic material, so didn't really have a lot of comment about that until good old 50 Shades of Grey came out. So after 50 Shades of Grey, I don't really need to say much about that. With all the splash of that and a multi-million seller and went platinum and all that stuff, there's no question about the fact that for some people, some stimulation to the mind is necessary. There was a study that was done last year that came out that looking at erotica. And I just want to show you this because a lot of times you ladies get mad at guys for looking at porn, all right? That's something you don't like us to do, you're jealous, you think that means that we don't desire you. Well, the study showed that was absolutely not the case, that there really was no decline in desire for the current partner in men who looked at pornography. But also there was a nice little part of that study that said men only looked at pornography for an average of 7 minutes a week, all right? Whereas women didn't think that reading 50 Shades of Grey was pornography. That was just stimulating. That was just something that girls did, right? So they might read 50 Shades of Grey for 7 hours a week and not consider that erotica. Whereas they got mad at their man for looking at the porn site in 7 minutes. And I'm not trying to start a fight here other than to say men are visual. That's just what we do. And I don't have the time to get into what that all means in a relationship. Obviously, to some women that's very important that their partner doesn't do that. But clearly we need different stimulation. A woman needs stimulation not just from visual, not just from auditory, not just from, it all has to be right for a woman. And recognize what you need and ask that of your partner. There are some sexually enhancing products. If you can't get an orgasm the way you used to, we'll get a vibrator. There's lots of nice little stores out there you can go to, 3 or 4. They're very tasteful. It's not going to be smut and all over the place. There's not just, like I said, a cigar smoking fat guy behind the counter that you don't want to park in front of. And I'm not going to promote any of them because they're all on the web and you can find them here in town. And then if you're not getting that response, find a good sex therapist. Not just a therapist that likes to talk to you about sex, but really a board-certified sex therapist is one you need to speak to. And there are 3 here in town. I'm going to skip Eros because it's kind of fallen out of favor. Unfortunately, there are no FDA-approved products for women for sexual function. We do a lot of things. We use Viagra, Levitra, Cialis in low dose in women. It can work, particularly for women who have problems with orgasm. It can improve their orgasm. But we've had lots and lots of research. And the thing that's frustrating to us sexual medicine doctors is that if the PDE5 medications, Viagra, Levitra, Cialis, and now Stendra, were coming out now, and they had the same FDA restrictions that female sexual medicine products did, they never would have been approved. They were so strict in the safety guidelines and the efficacy guidelines. Levitra had the exact same benefit-risk ratio for its clinical trials that they've used to turn down the last 5 products that have been put before the FDA for female sexual medicine. It's a big bias. There are websites out there. There's a growing concern and sort of trying to get congressional pressure on the FDA now to be a little bit more, I wouldn't say looser, that's not the right word, but fair. If you're going to use the same risk-benefit ratio for men as for women. So testosterone. Really, testosterone is the hormone of desire in both men and women. What we are learning about testosterone in the modern day is it's critical for women. 5 years ago at my sexual medicine conferences, testosterone was sort of a throw-in hormone in women who were on estrogen who wanted to restore sexual function. As more information came down the line and we found out more about testosterone, it's critical. It's not just critical for sexual desire. It's critical for vaginal health, we're finding out now. It's certainly critical for bone density, muscle mass, and cognitive function. All of these things are much more important. So the FDA, when these testosterone products were being looked at for women, surely thought that they were going to be able to kick these out forever. So they said, not only do you have to continue these women after the clinical trial, but you have to continue them on therapy for 5 years. Some you have to stop at the end of the trial. Some you keep on placebo, and some you keep on testosterone, and you follow them for 5 years. They were sure that they were going to find out this stuff was dangerous, okay? Well, it turns out that the best group was the women who continued on testosterone, and all those parameters I just discussed with you. And the safety was absolutely fantastic. No increased risk in cardiovascular disease, stroke, blood clots, breast cancer, uterine cancer, and overwhelming benefit in terms of the things I talked to you about. Cognitive function, muscle mass, and bone density. So these things are very important to women as they get older, and I think that as this data comes out, it's going to be very difficult for the FDA to suppress this. So let's look at aging and illness. Now, obviously, when there is a serious illness, sex can be the worst thing in our mind, and we just want to get our health back. But when you have chronic illness, let's say that you're a terminally cancer patient, sexuality can actually be a very important part of letting go. And I have had many patients who I counsel, and I always tell patients, you can do it, because I got a couple who she had a radical hysterectomy and radiation for cervical cancer and had such bad vaginal narrowing that there's no way to have intercourse, all right? And he had a failed penile implant after radical prostatectomy for prostate cancer, so he can't get an erection any kind of way. And that couple makes love 3 times a week, both to orgasm. They have one of the most satisfying sex lives you ever see. So they're sort of my hero couple. They're the ones who, if they can do it, you can do it too. So I say you have to find a way to go. Now sometimes if you're hurting, you're getting chemo, you're chronically ill, you have no energy, obviously you need to time intercourse. It needs to be on your best days and things like that. But don't think that sexuality has to go away because we're getting older, we're getting ill, our bodies are declining. So I think it's important to find a provider you can talk to. If your provider doesn't talk to you, you need to find somebody who can. Your partner is not a mind reader. You know, I always say that I am a sexual medicine doctor, and I find it very difficult to talk to my partner about sexuality. So I know this is kind of a, little bit of a hypocrite here, but it is important to find a comfort zone, because you find that by communicating, you overcome a lot of the restrictions that you have. You may find things that your partner needs. You may find you're doing things your partner doesn't like at all, and they're huge turnoffs, because it's hard to talk about sex. It's very hard to talk about sex. And just recognize that if things don't work, sometimes it's not them, it's not you, it's the body declining. So when your partner is no longer able to get an erection, don't think it's because he's got somebody else. Think it may be that canary in the coal mine of a low testosterone or a high cholesterol causing vascular disease, and get him to a doctor. Or in your case, where you can't have comfortable intercourse, don't think that it's just the way things should be. Think that you may have severe vaginal atrophy that is another canary in the coal mine of the loss of estrogen in your body, and you need to see a doctor also. There we go. Start talking. Keep talking about it. Find a comfort zone. If you can't, find somebody else. Maybe even get a book. Use images. Sometimes, whatever it takes to get us going into talking about sex. So I just want to say that recognize that you don't have to give up sex. There's an old saying that if you don't give up on sex, sex won't give up on you. It won't be the same as we get older, but we can still do it. It can be fulfilling. Very important. One of the most important messages I tell couples is you've got to redefine it. If we think that penis in the vagina sex is both partners getting mutual orgasm at the same time, just like in the movies, is the only way to do it, then you're going to be disappointed as we get older. Recognize that you've got to find different ways, like that other couple, of being able to satisfy each other. Make sure that you do it when you both feel good about it, and recognize that for many couples, when they quit having sex, they quit having intimacy, and that is too high a price to pay. Touch is so important, and if intimacy is the only way that you and your partner connect, sexuality is the only way that you and your partner connect with intimacy, then don't let that go. Or if it has to go for physical reasons, make sure that you find other ways of being intimate to replace that, because that is too high a price to pay. Any questions?
question?
Yes.
What
Yes.
about when, I have, there are people, when you've got a sick, when you talk about a person being ill, one person has Alzheimer's, and it's not the wife, it's the husband. I think it'd probably be easier if it were the wife that had the Alzheimer's. But the husband has the Alzheimer's, and the wife is caring for him all day, and then he wants to have sex at night, and so when if there's such a great disconnect, how do you pull some of those things together without, I don't know,
The question is, how do you deal with the disconnect in sexual desire in someone who may be disinhibited, like an Alzheimer's patient, particularly when it's a male? That's a tough one. We wish we could have an anti-Viagra, right? That would be the antidote to Viagra. You educate the patient, particularly the caregiver. There is a disinhibition for both. I will tell you that there's disinhibition for women. I have a 94-year-old couple who comes in, and he has to stay on testosterone because she's got Alzheimer's and she has very high desire. And he just sometimes rolls his eyes about having to take his medicine, to keep her happy. So it works the other way too. But there really isn't anything you can do other than educating her. And if he becomes aggressive, and then sometimes I think if there isn't one on board, sometimes an SSRI type antidepressant can depress desire just enough and function enough to help that. And I'll often recommend, if there's a psychiatrist in the case, to do that, to give them. And sometimes one of the more potent SSRIs in terms of sexual function depression is exactly what we need. But that's a difficult problem in counseling, this exhausted caregiver that when he wants to jump her bones in the evening, that's not exactly what she wants. I hope that answered your question. Yes?
On the study where when they used the estrogen and the testosterone, were these women already on estrogen and they added testosterone, and were they recent menopause, or had they been menopausal and then they were put on hormone replacement? Because there's such a controversy about how long they should take it and so forth.
The question is about, in the patients I alluded to about testosterone and estrogen. As you can tell, I went over that quickly because of the controversy. Peggy and I give a talk on that, which is about an hour-long talk, and that barely touches the surface on it. There's actually a very nice documentary out there, I think you can even get on YouTube, called Hot Flash Havoc. I didn't name it, some females did, Hot Flash Havoc. It's by my friend Alan Altman and a bunch of people from the North American Menopause Society and ISHWISH, my other organization. And it's a great movie for covering this controversy in about an hour and 20-minute documentary. And it's very fair and weighs in on both sides with experts and people who know what they're talking about, not just scare tactic doctors, which is a lot of the people that are out there about hormones. But to answer your question, it is difficult because I was assuming that someone either still had enough estrogenization after menopause, and we were talking about adding testosterone, or was going to get it. I'm a strong proponent of hormone replacement therapy. That's a big part of my practice. I think it's very safe if done in the right patient. Clearly there are groups in which it's controversial and contraindicated, but I think the problem is that women have not been counseled appropriately. They haven't been given the whole story. It takes me 45 minutes in my office to discuss the risks and benefits of hormone replacement therapy. I draw labs, I individualize it, I measure, I do all these things. It's not take your Primin and come back next year for your annual. And that's where we got into trouble with that sort of approach to hormone replacement therapy in women. So yes, it is safe when done carefully. The benefit is that if you're on estrogen alone, all studies have shown that adding testosterone to estrogen helps with sexual function. Now we're seeing that adding testosterone to estrogen helps with all manifestations of hormone replacement therapy. And again, the sort of the state of the art from our meetings is that if you're not giving your patients testosterone, or at least strongly counseling them that that's an essential part of it, then you're really not practicing state-of-the-art hormone replacement therapy. I hope that answered your question.
Is there an age limit?
I've got 84-year-olds coming in and holding me by the neck. If you don't give me my refills, I'm going to find somebody who will. Yes, you shouldn't start it after many years. That was some of the worst parts of the WHI, that study that started all this controversy, was that many women in their late 70s who hadn't had hormones for 25 years were started on relatively high doses. Now we know that's very dangerous. So is there a time frame? Clearly below 60, it's very safe, okay? Between 60 and 70, you need to individualize. After age 70, it needs to be extraordinarily individualized and cautiously given. I hope that helps. You had a question in the back? You had a question? Yes.
My question was on the connection between the disinhibition with the Alzheimer's patient and the increased need for sexuality.
Well, that happens in a lot of Alzheimer's patients. I have male patients, and some of the subtle, this is more your field than mine, some of the subtle signs of dementia are that disinhibition. You'll see a man who's been perfectly straightforward all his life who becomes way out there and maybe even, coming on to young women and things like that. And to me, I don't see that as, in someone who wasn't that way before, I see that as a problem. So disinhibition can be a real challenging part of this for the Alzheimer's patients. Anyways, yes?
You had one of the notes about natural male enhancers. You didn't mention anything.
So we're not fans of those. And we're not fans of the low-T clinics and things like that. Not because they ruffle our feathers. They ruffle our feathers because they're not done right. There was a study that the FDA commissioned, and they looked at the top 60 complementary and alternative CAM products, complementary and alternative medicine products. They analyzed them by FDA criteria, recognized that for a pharmaceutical agent approved by the FDA, you can have no more than 2% batch-to-batch variation in your product, or they take you off the market, and you've got to come back and prove that you're steadier than that. So with the CAM products, there was a greater than 40% batch-to-batch variation in quality and concentration. There was also a greater than 45% alteration in actual ingredients, meaning they didn't have what they said they had in there, or they had something else in there that they didn't claim to have in there. So because of that, I think any of us who practice medicine have to be very cautious about these products, even in something that we know very well, like some of the natural hormones. So we've had lots of problems with the male enhancement products. They've had testosterone in them, they've had Viagra in them, they've had yohimbine, they've had all sorts of different things in them that could be very dangerous to patients depending upon their medical condition. So we don't recommend any of those. In fact, I think they're dangerous. We see young men getting those. They have testosterone in them and they come in and they've lost their sperm count, for instance. I saw that in a 28-year-old who took those for about 6 months. Okay? Yes. But thank you very much. I enjoyed it.
Thank you so much, Dr. Vinca, for that very solid. That raised my attention a couple of points. Thank you. Okay, we're going to take a break before our next talk. Our next speaker is scheduled to be here at 3:15. It is now about 2:45. We'll take about a 20-minute break, about 5 after, and we'll see where we're at. So come on back and check on us in about 20 minutes or so.